Good morning, everyone. Welcome to the 2025 Wilcoxon Innovation in Health Sciences Summit. It's wonderful to see so many people here. We have our students, some faculty and staff, some guests, a member of our Board of Governors, and many community members. So it's going to be a great day as we look to and celebrate the future, really, of health science and healthcare. This is an important event for Missouri Southern State University. As many of you know, we are providing a focus on health science and working with others in our community to advance Joplin and the region in an area that is really a strength for the four states region, and especially Joplin. I really want to thank and recognize individuals who made this possible. Later today, Dot Wilcoxon and her son Philip will be joining us. They'll be there for lunch, so I hope all of you could be part of that. But this simply would not have been possible without the generosity of Dr. Bob and Dot Wilcoxon, and we're tremendously grateful. Also at lunch, you will meet the 5 students who are Wilcoxon Scholars who are working on undergraduate research projects with our faculty. Also, I want to thank the Planning Committee, actually it should be called a Planning and Execution Committee, who have worked and are working very hard to make today a special event. So at this point, I'm very delighted to introduce our MC for today's event, Vicki Meisler. I'll tell you a little bit about Vicki. She currently serves as the Chief Administrative Officer at Ozark Center here in Joplin, Missouri. Having been with Ozark Center since 1984, she's held many roles there and has had the opportunity to be very actively involved in advancing healthcare at both the state and national levels. Beyond her work with Ozark Center, Vicki serves on several boards, including Art Feeds, Seroptimus International of Joplin, and the Missouri Southern Foundation. All of these organizations are dedicated to improving the lives of others and improving communities. Vicki, we're very grateful that you've agreed to serve as MC today. Please welcome Vicki Meisler.
Good morning, and welcome again to the Wilcoxon Innovation in Health Sciences Summit. It's an honor to serve as your Master of Ceremonies today. This is a really unique opportunity to explore the latest advancements in healthcare technology and future trends shaping our industry. Over the next few hours, we'll delve into some cutting-edge topics, engage in interactive discussions, and hear from nationally recognized leaders in healthcare. As we begin this summit, I encourage each of you to actively participate in the discussions, share your insights, and collaborate with your fellow attendees. Together, we can inspire innovation, educate one another, and pave the way for groundbreaking changes in healthcare. I'm very excited to introduce our keynote speaker, Dr. Marilyn J. Heine. She'll be discussing strengthening the focus on precision healthcare with an AI twist. Dr. Heine was elected to the American Medical Association Board of Trustees in June of 2022. She's an emergency physician specializing in emergency medicine and hematology oncology in Southeast Pennsylvania and serves as a clinical assistant professor in the Department of Medicine at Drexel University College of Medicine in Philadelphia. Dr. Heine served as chair of the AMA Council on Legislation, as a board member of the AMA Political Action Committee, and as a member of the AMA Private Practice Physicians Congress Governing Council. She's held prominent leadership positions in several state and specialty societies, including president of the Pennsylvania Medical Society, Pennsylvania College of Emergency Physicians, and Bucks County Medical Society, where she continues serving the executive committee. She was the chair of the American College of Emergency Physicians Federal Government Affairs Committee and lead representative to the Core Quality Measures Collaborative, as well as the legislative director and board member of the Pennsylvania Society of Hematology and oncology. A national speaker on health policy, physician advocacy and scope of practice, and emergencies in hematology and oncology, Dr. Heine has testified before Congress on Medicare physician payment and is widely recognized as a trusted resource by policymakers on both sides of the aisle. Dr. Heine has received many accolades, including the Pennsylvania College of Emergency Physicians David Blanc Award for Outstanding Contribution to Emergency Medicine, the inaugural American Medical Association Political Action Committee Award for Political Participation, the American Medical Association Women Physicians Section Inspiration Award, and the American College of Emergency Physicians Colin C. Rory Jr., PhD, Award for Excellence in Health Policy. Let's give a warm MSSU welcome to Dr. Marilyn Heine.
Well, thank you so much for that warm welcome. We really appreciate it. Also delighted to be here today. Getting to know people from Missouri Southern State University has been truly a delight, and it's been an honor to be invited here to present to you. So we're going to go over now strengthening the focus on precision healthcare with an AI twist. And to do so, we're going to actually delve into it. I have no financial disclosures. And we're going to define precision healthcare and recognize its key components. We're also going to describe the benefits of precision healthcare and go over some case examples, use cases, and hopefully have some interaction from you. Even though we don't have response devices, you can certainly yell out or show your hand, or we'll just engage in another way to help you feel part of this presentation. And we're also going to identify the role of AI in precision healthcare and recognize that there are challenges to realizing the potential, but also we can not only recognize them, but take steps to advance precision healthcare and to address these issues. So first, a brief introduction to what the American Medical Association is. So the AMA, who are we? We actually are have a mission that is to advance the science of and art of medicine with definitely assessing the betterment of public health. It's always been a striving for us to do that. And with regard to our history, we've been founded over 100 years ago, and it's important to recognize that we have largely a national focus, but we also have a very robust state advocacy unit called the Advocacy Resource Center, and we engage federation-wide, which means we engage with state medical associations across the country, including the Missouri State Medical Association, that is doing wonderful work, by the way, and also we engage with the federation partners and specialty societies. We have certain publications that may be particularly of interest to you, especially considering the focus of today's talk. The Journal of the American Medical Association has a series that's specifically on AI that we prefer to call augmented intelligence at the AMA, because we want to ensure that the physician or clinician is in the loop on that. And also, EdHub is an educational platform that has wonderful resources, including on precision healthcare and AI. And I'll point some of those out at the end of the session so that you can snap the QR codes and go to those and learn some more, and that would hopefully be a rewarding experience for you. Our policy at the AMA is developed by a collaboration across the Federation. Over 190 state and specialty societies gather together twice a year to develop AMA policy. We also have other critical stakeholders involved in that. So the AMA actually has 3 key arcs to the strategic plan. One is driving the future of medicine. And we do that, actually, a big focus is on continuing professional development. So a summit such as this is an excellent example of something that the AMA highly values because of the importance of the professional development. A second key component, a key arc, is to actually lead the charge to confront chronic disease and address public health crises. And in doing that, clearly precision healthcare and AI are key components of that would allow better focus and allowing, hopefully, an improved outcome for chronic disease and removing the barriers that would interfere with patient care. Underpinning all of that are principles of equity, advocacy, and innovation. So we have a campaign, so to speak, that's called Why We Fight. So we really try to fight for physicians and to make sure that key issues that are of paramount importance to the practice of medicine are addressed. To learn more about the 5-point plan, please see the QR code on the slide. But particularly relevant today is the component of that 5-point plan that asks for us to really focus on ensuring that the future of digital health works for physicians, that it helps in really strengthen the patient-physician relationship and really moves medicine forward. And so the AMA is committed to making technology an asset and not a burden in the clinical environment. We are working to ensure that innovation in healthcare is evidence-based, validated, equitable, actionable, and strengthens the patient-physician relationship. The AMA is actually a steward of innovation, very involved, and it gives the physicians a platform to engage with tech innovators, entrepreneurs, and policymakers at every stage of development. And AMA is working to ensure that physicians understand that in the rapidly evolving digital health landscape, that we have the tools, training, and support to harness the power of technology, from telehealth to AI-enabled tools. All of that in the exam room so that it will aid the physician in taking care of the patient. And simply, we are fighting to make technology work for physicians. And the AMA anticipates that there are disruptive forces. We see them all around us, and that these will continue to shape the future of healthcare and we need to therefore provide the legal, ethical, and policy guardrails to help navigate the ever-changing landscape of digital medicine. So since our first policies on AI were adopted in 2018, and just as a side note, I was really honored to be part of the Council on Legislation that worked on those initial policies, the AMA has continued to refine its policy and guidelines with the evolution of AI technology in healthcare. And there are many reasons to be super excited about AI and AI-enabled healthcare tools, including the opportunity to expand access to care and create greater practice efficiencies. But we have learned from the experience, such as with electronic health records, that if health technology is not designed and built correctly, leveraging clinical knowledge and expertise from physicians, the technologies run the risk of failing to deliver on their promise and, in fact, exacerbating health inequities and worsening the outcomes for patients and increasing the burden for physicians and other clinicians and burnout that our profession suffers. So it's critically important that we help move this in the right direction. So precision healthcare has certain key goals, and as was attributed to former Secretary of Health and Human Services, Michael Levitt, is really to have the right treatment for the right person at the right time. And the 3 key goals are improved effectiveness so that you can target specific conditions and you have enhanced patient safety because you understand how a particular treatment or a particular situation for a patient will actually affect them, and better outcomes, better improved quality of life, because it is not one size fits all. So there are 4 P's of precision healthcare. One is predictive. So we use data and analytics to predict disease and disease progression and allow early intervention. So one example is if you have a patient in your clinic whom you know meets criteria for being considered at high risk for lung cancer, that you actually will perform or arrange for them to have a low-dose CT scan of the chest. Because with that, we can find early lung cancer. As you may know, lung cancer, when it's advanced, has a very poor outcome, but when it is found in an early stage, you have a much more promising outcome for the patient. So that is really key to be able to detect early, something that was not feasible before. Another aspect of prediction is, you may know that women who have breast cancer, we always assess whether they have hormone receptors on their breast cancer cells. So estrogen receptor or progesterone receptor. And this is important because it helps us to understand whether they are likely to respond to a medication that blocks the effect of estrogen on those cells and helps to stop the growth of any residual cancer. Also, you may be aware that in lung cancer, as well as other disorders, but it really comes to the fore with lung cancer in particular, lung cancer has certain mutations we've found on the cells that if we can target that with particular agents, an antibody to that protein, for example, we can help stop the growth of that lung cancer. And in any situation, whether it be lung cancer or one of the other malignancies, if we can do treatment in a targeted way and we can avoid chemotherapy for the patient, we can help really hopefully provide a much more promising and positive outcome for the patient and a better quality of life. As you may know, chemotherapy affects cells that are rapidly dividing throughout the body. And so there's obviously hair loss, blood count going down, GI effects, a multitude of conditions that if we can use targeted therapy that avoids those potential toxicities, it can be particularly helpful for the patient. And then we also can move to another P, prevention. So we can helpfully prevent the advancement of disease. We can have, again, certain targeted approaches. So you may be familiar with the diabetes prevention program, because that's an area where personalized and precision healthcare is helpful in that space. And so the hemoglobin A1C, if you find a patient who has a slight elevation so that it's in the pre-diabetes range, and you can counsel them and get them into a diet and exercise program and hopefully work on bringing down that hemoglobin A1C, you can hopefully move them to a healthy state and not where they would otherwise advance to full diabetes. So that's a key area. We know about certain measures that you use to prevent heart disease. So lipid management, hypertension management, those actually are initiatives on improving health outcomes that AMA is very much involved in. But for that, those key issues, if you can address, you can hopefully prevent severe heart disease for a patient. And then with regard to cancer, so an example on that is preventive screening, such as colonoscopy. So if you have a patient and you advise them to have colonoscopy and they do that, then if they're found to have, let's say, an adenomatous polyp, a growth in their colon that could otherwise go on to develop colon cancer, and you have that patient have that removed, and then they could be spared the evolution of their disease to colon cancer. So it is definitely life-changing. On the personalized aspect, you can tailor treatment, and you can also adjust to have their lifestyle and environment addressed as well. And so, for example, there are ways that you can actually assess if somebody is at risk for familial hypercholesterolemia, and if you can bring down the cholesterol and prevent them from having heart disease at a very young age, that could be particularly impactful. And then, of course, the mutation-targeted cancer treatment that we do. So with participatory, as you know, you may also be wearing wearables yourselves, potentially, and the patients are also engaged on that. So that information can feed into the record and can also affect if somebody's going to have an impact. You can use that data and help to counsel the patient and get them through their self-monitoring. So it's a very participatory effect. There are 4 unique factors that are considered when we look at precision healthcare. One is genetic. The DNA analysis gives us a sense of the risk of disease and it helps us to perhaps assess the response to medication and treatment. One example of this is the BRCA mutation. You may be familiar with that. The BRCA1 or 2 mutation has these patients, these women, at significantly increased risk of breast and ovarian cancer. And there are women who, when they're counseled, they may wish to opt for prophylactic surgery for removal of those organs so that they don't have that adverse effect of the genetic mutation. So it's definitely a serious conversation because there are definite upsides and downsides, but it's really important that the patient be involved, that it's shared decision-making, and they are aware of what the potential risk is. Newborn screening is another area which is being addressed with genetic screening. There are neonates in the NICU without a diagnosis as to why they have a particularly challenging situation. Someone, for example, who has unexplained seizures, something where you really, if you could do the genetic screening, the genome profiling on those neonates, you can actually come to a diagnosis that could be helpful for the patient. Biomarkers is a second area that's a unique factor. We do that through blood tests and imaging, and with regard to one that you may be more familiar with is the hemoglobin A1C. So we already talked about how that is important in screening, and we also use that as a biomarker to see how well the patient's diabetes is being controlled. We also have psychosocial component, and this has been recognized really for over a decade when we recognize that mental health, social support, and socioeconomic factors have really been pivotal to saying that it's not just the genetic makeup, but there are these other components that really affect how the genes are expressed. And someone, for example, in the psychosocial space, they may have a home with lead paint, and obviously that puts them at risk for adverse effects from that. On the phenotypic, that's how someone presents to you, let's say in the clinic, and they have new lightheadedness, they may have a heart murmur that suggests decreased outflow through the aortic valve. If there's narrowing there and stenosis, you might be able to help guide them to an intervention that could really improve their quality of life. So we know that there's a genome, that's all the DNA in the patient, only some of which is expressed, which is called the exomes. And this is essentially the operating manual. It makes all of our cells and our tissue, but that isn't the sole factor that contributes to how we actually present as a patient or someone in the community. So there are a couple of intervening steps, but also just remember that DNA is not destiny. It's influenced by something that you may call the exposome, which is the lifestyle environment factors. And that leads on to then how someone is presenting. So the phenotype, their medical history, physical exam, the nature of their disease, whether it progresses or responds to treatment. So there's some really important landmarks in the history of clinical genomics, and we'll just delve into them briefly. But one is in 1956, that was the first time that there was actually a chromosomal analysis. And in the 60s, they were able to do karyotyping. So for those of you who may know the trisomy 21, which is how we understand Down syndrome, that was identified at that time. Also identified in the hematology space was a chromosomal translocation, a part of chromosome 9 and 22, and that was called the Philadelphia chromosome. And I don't bring that up just because being from the Philadelphia area, but it actually was something that was discovered in Philadelphia. And it wasn't totally understood what the significance was, but we knew that those patients had chronic myelogenous leukemia, that there was that association, but we didn't understand the driver for that. However, later, it really led to really an impetus to understand if there's a chromosomal translocation, something different about the genetic makeup in the chromosomal panel, and the patient has a high association of that change with the disease, that we need to find out what is driving that finding in the chromosome panel with the finding in the patient. So the genetic research was really incentivized by that observation. Subsequently, there were different techniques that were identified that were really helpful, and so a series of them. And subsequently, in the 2000s, the landmark completion of the Human Genome Project. That was in 2003. It was a 13-year endeavor, and that was clearly a very important foundation of research that we were able to then lean on. It also incentivized in the UK work in the same area, gathering 500,000 patients to contribute their genetic makeup so that there could be a vast cohort of patients for study. And at that time, we were developing the next-gen sequencing, which was really essential to getting a better handle on what the patients have in terms of what their genome profiling is. And subsequently, there were other initiatives coming in the United States and elsewhere to really gather large cohorts of patients. And again, here was where they understood there may be a psychological influence as well. At that time, we were able to analyze genes and person's genomic makeup even more extensively and even with greater refinement and more comprehensively in the 2020s. So with genome sequencing, again, there's the whole genome, there's the germline, which come from parents, and somatic makeup, and the exomes are the ones that are expressed. And then we have so they were able to do studies on those as well as targeted gene panels. And more, the research is showing that the more broadly a patient's genome makeup is assessed, the more information of value we can obtain. And so we want to be able to understand which genes cause disease and which actually are whether we can use them to determine what treatment, how they're responding, what their prognosis is. So here's another area that was particularly impactful in cancer treatment. So you may be aware that in our bodies, we have the capacity to have our own immune system be able to regulate and fend off things that are foreign. But sort of that if the cancer, you give it a mind, the cancer knows that also. So what happens is there's certain factors that modulate and decrease the T cells, which are important for fighting off things that are foreign. It may decrease their activity. So if a tumor amplifies those checkpoints, as we call them, immune checkpoints, and these are, for example, we call PD-1 or PD-L1 or CTLA-4, their names aren't as crucial as the role that they play. If you can actually identify that through genomic profiling that your patient has a particular amplification of this substance, of this factor, then you can see if the patient can have an immune checkpoint inhibitor infused to dissipate these checkpoints to then allow the mighty T cell to go and fight off the tumor. So that's immunotherapy in a cartoon form, but it is really essential to understand that that's the basis for that treatment, and it can be very helpful, again, for that select group of patients where these amplifications are found. Let's move on to biomarkers. So again, there are basically 5 types of biomarkers. There's the diagnostic, where you can identify a disease through that. There's the prognostic, where you can assess the likelihood of response. There's the pharmacogenomic. And backing up to the diagnostic, an example on that could be hemoglobin S. As you may know, patients who have sickle cell have hemoglobin S. And then the prognostic, you can assess a patient's risk for prostate cancer by using the PSA. And the pharmacogenomic, we're going to get into a couple examples, but let's do the first one here. Raise your hand if you've heard of G6PD deficiency. Anyone? A couple of you think. Thank you. So with that, we understand that a patient who has G6PD deficiency is unable to metabolize certain medications. And in that, what happens there is, let's say you have a patient who comes in with a urinary tract infection, and you know that, for example, sulfamethoxazole, trimethoprim, that is a medication that you would readily use in someone who has a urinary tract infection, uncomplicated. But you know they have G6PD deficiency. So you are not going to give that medication, because if you did, that patient's red blood cells could then break down. They could have hemolysis. That could be a severe effect from that. On the predictive side of things, you can use biomarkers to determine someone's potential response to treatment. So we talked about the translocation, the the 922 translocation that was identified decades ago, more recently, in the last several decades, we understand that that translocation has led to the production of a protein that then drives, it's an enzyme, tyrosine kinase, it drives the cells to developing the chronic myelogenous leukemia. So previously, patients who had CML or chronic myelogenous leukemia would have to have, oftentimes, depending on the severity of their disease, a stem cell or bone marrow transplant. Potentially, it would be a disease that was fatal for them. So then when we have this understanding of that fusion protein creating this tyrosine kinase that drove the CML, we could intercede. So there was a drug called imatinib. That was one that was presented, and there have been other versions since then, that actually inhibits that enzyme and dramatically changes CML from a disease, as we said, that had a very potentially rocky course to one that is chronically managed and the patients tolerate this treatment well. So again, a very dramatic effect. With regard to monitoring, we can detect early signs of disease, and that could be, for example, someone who has congestive heart failure, you're monitoring them to see if they're having an exacerbation, and you can see that their BNP, their brain natriuretic peptide, is going up, so you know that you have to intercede with something to try to prevent that from worsening. Another area where we can use monitoring biomarkers is circulating tumor cells. It's not as broadly used, but it's getting there. And if somebody, particularly who has metastatic disease, you're monitoring them to see what their response to treatment is, then if you can measure circulating tumor cells, which is the liquid biopsy, you can assess whether they're having a response or not. So let's go into case one. Mrs. Forrest is a 42-year-old patient. She has colon cancer, and Dr. Brown is aware of biomarkers that are important in Mrs. Forrest's care. Which of these biomarkers are relevant to Mrs. Forrest? So her CEA level decreased after she had resection of her tumor. So that type of biomarker, again, is diagnostic, and then because it correlates with the magnitude of her disease. How about her tumors markers correlate with the mutations, correlate with the increased risk of recurrence? Yes. We screen these patients. We try to find what mutations a particular patient, for example, with colon cancer has, because that helps to guide the treatment. We understand there are certain mutations that are high risk for recurrence, and we want to make sure that we address that disease differently than someone who has a lower risk of recurrence, a patient who also may have a higher risk of family members who have the disease as a result of a mutation. So it's really helpful to understand, is the mutation just in the cancer cells, or is it more broadly? So that is a predictive marker. Then how about she will have a gene test to assess her, whether she has metabolism of the 5-FU. So 5-FU, 5-fluorouracil, is a medication, a chemotherapy medication, that's used very commonly, particularly in colon cancer. But we understand that even though it's commonly used and most patients tolerate it very well, we understand that there are a subset of patients who do not have the ability to metabolize the 5-FU, and they can have a potentially lethal adverse effect. Lethal. It really is critical to understand that potential risk and get the gene study if you're going to put the patient on this medication, because they may not have any other manifestations of this genetic deficiency, but if you identify it prior to giving them treatment, then you can dose reduce them so that they don't have such a really potentially tragic outcome. So that's a pharmacogenomic biomarker. And how about our clinical course differs related to the side of the colon cancer. So interestingly, there are patients who we might realize through the literature, studies have reported that if someone has a right-sided versus a left-sided colon cancer, it has a different prognosis. So that's a prognostic biomarker. And then again here, circulating tumor cells may detect early recurrence. That was a monitoring biomarker. So let's jump into the exposome. That's more the lifestyle and environment. The epidemiologists have coined this term several years ago. I think it's helpful there's increased interest in this particular concept. And so what happens, it's really what you're exposed to, right? So if somebody has personal factors, maybe they have a history of substance use disorder, or they have, a living environment that's not as optimal, or, whether or not they exercise, which will be a positive effect. There are things that we have to identify in the patient these are personal factors in their exposome. There are also external factors. Maybe they're in an area which has high pollution, or maybe they're exposed to certain other toxins, or maybe they have other factors outside. So if they're living in a green space area versus a very congested one, different factors can be external factors for them. Both the personal and the external lead into biological responses. And so one of the things that obviously we're particularly focused on is the gene expression and how that manifests itself in the patient. And these are other elements of the biological responses. So let's jump to the clinic. You have a patient who comes in, let's say she's 68 years old, and you want to know what are her exposome type factors that we should consider in assessing her risk and assessing how we're going to help manage her, and what factors she has exposed to her on a regular basis that we need to account for when we design a treatment plan. So one of the things you may want to inquire is she living in an area with high pollution, or does she have beautiful, clear skies on a daily basis? Does she smoke cigarettes, or does she have good hygiene, including good sleep habits? Does she live in an area which has a lot of congestion, a lot of traffic, a lot of stress? Or does she release and have exercise and gather with other peers so that she has a sense of community and positive health habits? Another thing that we should consider is what exactly is the level of function for a patient? What are their activities of daily living? Is this patient that you have before you someone who is able to walk, dress, bathe, eat, toilet, and get up from a seated position independently? Or how are they functioning on the instrumental ADL, or activities of daily living list? Can they actually cook or clean, take their medications, bank, go through their mail effectively, answer the phone, or drive? Paramount in any patient-physician relationship is the importance of patient-centered care and the importance of what are the patient's values and priorities and personal goals. We always want to meet the patient where they are so that we can understand what their thoughts are, what their desires are, and what is their understanding of what is happening, and make sure that we address any concerns that they have so that we can work together on the course of treatment. So we know that AI is crucial, that it drives precision healthcare. And not only does it drive precision healthcare, it's important to realize how. So clinicians, we rely heavily on pattern recognition, but AI does that to a different level. AI augments our human ability to analyze and interpret data that's complex and has patterns. And it also efficiently helps clinicians to develop and deliver a tailored approach. But it also, not only is it to be framed that way, but precision healthcare is truly the end goal of AI in clinical use, and progress is being made to get there. But it's important to recognize some limitations. Limitations exist on access to appropriate data, on the safe and effective AI-enabled diagnostics and clinical decision support, because they require large representative data sets. And we also recognize that bias could be present and is not fully addressed. So you have a patient in precision healthcare. You want to tailor your management with conversations with the patient to the patient. So you have the genetic, biomarker, psychosocial, and phenotypic data all coming together, being synthesized. AI is doing that, and then it helps guide the physician in caring for the patient. It doesn't supplant the physician. It helps aid them, and it helps guide them with regard to conversations with the patient on prevention, diagnosis, treatment, and prognosis. So physicians' priorities for digital health are, we want to know, does it work? Obviously, there are some new shiny tools out there, but is it really going to work? And not only is it going to work, will it work in my practice for my patients? So, for example, if an algorithm was developed in a cohort of patients who are in an urban area, in a different area of the country, a very different circumstance than somewhere which is that is less populated, that is more rural, that has less certain aspects in terms of what the living environment is like, is a very different cohort. So we don't know if that algorithm will work in our patients, right? So we want to know what's going to work here. So make sure it's meaningful. Will insurance cover it? And who is accountable if something goes wrong? So AMA research, expertise, and policy advocacy around digital health help physicians answer these questions and ensure that health technology actually lives up to its enormous promise. So the AMA did a survey to assess physician sentiment on AI. And it did one the previous year and then last year. And so this is the data, the most recent data that was analyzed from the one that was done at the end of 2024. So with regard to, these are 4 points. There's a great deal more in that sentiment survey. If you'd like to learn more about the sentiment survey, I encourage you to scan the QR code on the slide. So we saw a shift, interestingly, with regard to physician sentiment about the potential for increased use. And we saw that 40% of physicians were equally excited or concerned. So that was a significant number. And interestingly, we saw that there was an increase from the previous survey. We saw there was an increase this time in those who were more excited than concerned. It went up to 35%, and a commensurate decrease in those who were more concerned than excited. So those data points were showing some shift. We also understand that addressing the administrative burdens, about 57% thought that was really the key point that should be the most helpful part on the administrative side, and particularly with clinical documentation and coding and other aspects that are here. Those were the key factors on the administrative side that physicians thought there would be greatest enthusiasm. And with regard to a particular ability to have more confidence in the AI, physicians, really 47% said that it should have significant oversight by FDA to make sure that there are safeguards in place. So let's go to case 2. Mr. Hale lives in a rural area, and it is difficult for him to attend frequent appointments with his primary care physician. He has diabetes and heart disease that require regular monitoring and occasional adjustment of his medication. Dr. Sands believes that Mr. Hale's zip code should not influence his access to care or the quality of care that he receives. I'll let you look at this question when I take a sip. Okay, so what are some ways that Dr. Sands can increase Mr. Hale's access to improved monitoring and diagnostics in his rural area? Oops, sorry, gave you the answer. An AI-based mobile health continuous glucose monitoring. Got that one. How about AI-based wearable to monitor heart rate and heart rhythm? You go with that one? Okay. How about Dr. Sands continues to learn about the latest developments and advancements? Maybe Dr. Sands is here. What do you think? Dr. Sands leads a collaborative multidisciplinary team. Also very important. So we recognize that every member of the healthcare team is very important. And Dr. Sands advocates for broadband for telehealth access. We understand there's some challenges on that, getting it out to some rural areas and some urban areas. So the advocacy needs to continue. So let's consider example AI capabilities. So we're going to have 3 cases so you can make sure you match them correctly. So identification. Identification is really key with regard to pattern recognition. So again, humans can do this well, but AI does it at a much higher level. Prediction. If you have a patient, based on a previous track record that they have, you can potentially predict if they're going to be needing more intensive services and maybe be able to intercede before that requirement is fully manifest. Summarization. We know about the volumes of medical records we often have to go through, but AI can actually go through those and summarize them and pull out the key points much more efficiently. And translation, it's not so much a linguistic issue, but there are certain ways of expressing things in medical terminology that need to go into another type of terminology, and it helps for that translation. And also, in addition to the linguistic part. And then suggestion. So somebody, let's say, is on a continuous glucose monitor, and the AI is detecting some aberrancy in that AI may be able to potentially present a suggestion of how to manage that a little better. So knowing that, let's go to case 3. Mr. Baker's history of cigarette smoking and age meet criteria for lung cancer screening. A low-dose CT scan of the chest is performed. Initial standard review of Mr. Baker's CT scan reveals no abnormality. But AI detects an abnormality suspicious for early lung cancer. Which of the following describes this capability of AI? So do you think it's summarization? No, it's not record review. Prediction? No. Identification? Who do you think's yes? Identification? All right, cool. Or suggestion? No. So that's identification. All right. Case 4. Mrs. Roberts presents to the ED with a cough and mild shortness of breath. Dr. Fletcher initially detects no evidence of sepsis, which for those who may not be in the medical space is severe infection. Dr. Fletcher's EHR, the electronic health record, is integrated with an AI platform that suggests early sepsis is present. Mrs. Roberts is further evaluated and managed for sepsis. So does that show us summarization? No. Suggestion? What do you think? No. How about identification? Not a pattern issue, but prediction. Okay, we're good with that. Very good. And then the third of these, the EMS transports Mr. Bird to the ED, and with recurrent ongoing seizures, and let's say this may be happening in the future. So Dr. Laird requests a prior medical record and is given a ton, right? So what happens? We want to be able to understand Mr. Bird's medical history and potential triggering factors. And Dr. Laird's ED has the ability to utilize an AI tool to review Mr. Bird's extensive medical history and rapidly present information that aids in the care. So that one, not prediction or identification, but not suggestion, but summarization. Summarization to the rescue. So just to go over some example clinical use cases, and you can look at this in greater detail on your own, but in the cardiology space, we know that an example clinical use could be EKG analysis currently. So on the left are current uses for AI, and on the right are more future-leaning ones. So in the future, it may be able to actually identify who might be at risk for progressing with valvular heart disease. On the left, identifying a melanoma is currently being used for, and it may have skin cancer identification at a more early stage with AI in the future. In the remote patient monitoring space, we know that remote patient monitoring can assess blood pressure deviations and help guide management for the patient. And in the future, it may actually be able to determine if the patient is following their medication regimen, which may be an issue that needs to be discussed to determine if that's not happening, why. And so you'd have that heads up prior to the patient coming in to the clinic. For neurology, on the left, we know that AI currently can help with EEG analysis for seizures, and in the future, perhaps even with wearables, have some sense that the patient may be having an impending seizure prior to it actually occurring. In the OBGYN area, currently AI can be used to identify fetal abnormalities, and in the future, it may be able to predict better who is at risk for postpartum hemorrhage, which, as you may know, can be a life-threatening outcome of delivery. On the left, for ophthalmology, currently we know that it can analyze retinal imaging, and really one of the forefront individuals in this area has been doing, with regard to AI, for about a decade now, diabetic retinopathy screening, really incredible work. And in the right, it actually may be able to predict who might be having significant worsening of vision. In pathology, we can use AI currently with certain immunohistochemistry screening, staining of the tissue with biomarkers. We can actually make much clearer diagnoses. And again, with pattern recognition, AI is really expert, so to speak, at that. And in the right, may be able to even identify more details about the patient and their course. On the left, for pediatrics, currently being able to detect critical illness, and on the right, be able to detect or anticipate developmental delays. And on imaging, currently to be able to detect and classify certain features, and in the right, be able to perhaps even delve down into what characteristics are part of that image that might even provide more of a diagnosis about that patient. So here's case 6. Mrs. Grover visits Dr. Norris for evaluation of a skin mole. Dr. Norris plans to use AI to help determine if the mole is melanoma. Which of the following factors should Dr. Norris consider if using AI in his patient's care? So take a look on the right. You'll see something that looks suspicious for melanoma. I also want to flag for you the blue lines that are around the lesion, just to keep that in mind as we go into the questions. So, should Dr. Norris consider if the algorithm was trained with data reflective of the patient's skin tone? What do you think? Is that important? It is, because if somebody has a different skin pigment, the way a particular skin manifestation, whether it be melanoma or a rash or some other condition, may present visually quite different. So that is a yes. How about if the algorithm was trained using images with markings that are leading to higher false positive rate? That's a yes. So keep in mind this study. There was a study that was done that had the AI trained, it was just for purposes of the study, trained using imaging, images, but they were with blue lines around them, like I showed you in the previous picture. And the AI would always call those that had the blue lines, they were trained to think those were melanoma. So then in the study, they took that and they said, okay, AI, do you think this patient has melanoma? And they called any patient that had the blue lines around the skin lesion melanoma, because they were focusing on the blue lines and not really looking at the lesion itself. So it was very interesting, but a definite learning point. How about if the AI tool developer accepts liability, since this is a high-risk situation? That's also crucial. So obviously the answer is all of the above. But let me point on point C. AMA strongly feels that the degree of liability should be taken proportionate to the risk of the patient. So if it's a high-risk situation, meaning you're going to diagnose somebody with or not melanoma, that's definitely a high-risk situation, because if you miss that, it could be life-threatening. So if you're going to depend on the AI to have that level of essentially responsibility in a high-risk clinical situation, then the developer should accept that responsibility and the liability that's associated with it. Now, here's a situation where Dr. Smith considers using ChatGPT to decrease the administrative burden of generating office notes for her patients. And she's aware that the technology has limitations in the clinical setting. So raise your hand if you use ChatGPT. Anyone? A few people. Yeah, quite a few. All right. So in the clinical space, obviously we know it can be used in a variety of areas and has great promise. But it's important when we're taking care of patients that we have certain things in mind. So what should Dr. Smith keep in mind? Which of these are among the current limitations of using ChatGPT or other we call large language models or generative AI in a clinical setting or for direct patient care? Do you think that we should be cognizant of the risk of incorrect or falsified responses? Yes, very good. So we should, because we know that the AI could actually hallucinate or bring information in that is not well-founded, and it's important to have independent verification in the clinical area in particular. How about the risk of bias, discrimination, promoting stereotypes, or inequities? Yes, because if the AI is trained on data that's biased, the output will be biased. So it's incredibly important that we recognize that shortcoming and we don't fall prey to that, because the AI doesn't know. It's not intentionally promoting bias, but if it's trained on data that's biased, that will be impacting the output. How about the risk of flawed training data? That's also a concern. And the reason in that is the data that is used may not be current. And interestingly, there's an article that said, and it makes sense when you think of it, the AI is trained on really basically what's out there on the internet. So if you're in an academic, if your articles that you really want to use for the basis of treatment for the patient are in, let's say, an academic journal that has a paywall, the AI may not have access to that data. But guess what? The AI may have access to Reddit, and we know Reddit is not peer-reviewed. So it's really important to realize that. Now, how about impacts on data privacy? This is also huge. Very important that there's also liability associated with that. Because if you have data that's really patient-specific data that you're putting into AI, that could put the patient's data out there for anyone to see. So crucial, we understand that there are cybersecurity threats as well, and so it's very important that we're cognizant of the risk that we're putting that data to if we don't be mindful of that. And so with not only cyber attacks, but you might have heard of HIPAA, right? The law that it's mainly an interoperability type of law with portability, but it has certain privacy components to it. It wasn't meant for that, but it does have privacy components. But guess what? ChatGPT is not subject to HIPAA. So you don't, and it's really important to understand that the safeguards are not there. How about liability? Yes, definitely on the liability front as well. It's very important to be cautious about that and to, again, we talked about ascribing the liability, lion's share, to those that are responsible for the development of the AI tool. And how about the absence of current regulation? Yes, it's not currently regulated. So really, we're really accustomed in many times to thinking that, oh, the data that we have is all HIPAA protected and not a problem, but not in this area. So it's really important to be cautious. And also another thing I just wanted to flag for you is the payer use of AI and automated decision-making. We understand that increasingly the payers are using AI to be able to say no more quickly. That's basically how it's used, with very little oversight by humans and no transparency. So AMA is actively involved in advocating for increased regulatory oversight, transparency, and audits. And then there was a prior authorization survey, meaning a sentiment survey or experience survey of physicians that it's done annually. And the most recent one had a question about this in there. If you want to learn more about the prior authorization survey, you can scan the QR code on the slide. But importantly, 61% of physicians felt that there was a definite concern about the use of AI and its impact on prior authorization and denials. So AMA strongly feels that the AI and AI-enabled healthcare tools should be designed, developed, and deployed in a way that's ethical, equitable, responsible, and transparent. And just a note about transparency. And so with regard to that, it's very important to have the transparency to the extent possible. We understand there are developers and there's some proprietary information, but to the extent that we can, because if we're gonna take on responsibility for some decisions we're making for patients, and we have that liability, we need to know how is this operating, what is the basis? Because physicians should understand that where they utilize AI-enabled tools and systems without transparency provided by the AI developer, the physician's risk of liability for reliance on that AI will likely increase. So it's crucial to have the transparency and have that be provided regarding the design, development, and deployment of these tools. So let's go over some barriers, overcoming barriers to precision healthcare and related AI, and how we can potentially overcome them or take steps to do so. So one of the barriers is the importance of protecting data privacy, and that's really central to trust. If our patients are going to know that their data is imported into an AI tool and they're going to have that potentially exposed, they have to be able to trust it. They have to be able to say if the health system in which they're participating or other way that they're engaging is going to involve AI, they need to be able to know that because the patient-physician relationship is paramount. And nothing should be in there to sever that. And so it's crucial. And so how do you do that? One of the ways, interestingly, is pooling a lot of patient data, and again, relevant to the community and the patient population you're serving, but having a lot of data pooled so that you can de-identify to the extent possible. And encryption and de-identification are helpful. And having the community engaged so that they have a say, they have a sense of being involved, and that it's not being put on them, but they're part of this. How about worsening equities? And that can happen between a person and another, a community and another, a health system and another. There may be certain ones that have great resources and others that don't. There should not be using digital health to widen the digital divide, but rather to bridge it. So again, there, the inequities must be identified, and we must be able to reach underserved communities. The infrastructure expansion. So this deals with really having the commitment to having an investment with regard to having the data aggregated and having the safety, privacy concerns, transparency, all those ethical guidelines, part of that. With regard to that, that's a community issue, but also a national issue. And it's helpful to know that, again, this has been addressed in some other communities and other data gathering and the governance for that, but still be mindful of that. The cost effectiveness, now with genome profiling and other ways of getting data for the patients, there's consideration with regard to precision healthcare. Is it worth the cost? Because there is a cost involved, but there's a cost involved of not doing it. So it's very important to realize that hopefully by having better patient outcomes and having it be with more benefit for the patient, that the financial incurrence that you have is actually more than at least offset by the benefit to the patient, so that it would be a cost-effective endeavor. The stakeholder collaboration is important, with leaders being there to provide resources, policymakers that help to advance the regulatory and ethical standards, and that the researchers develop and clinicians implement effective tools, and the patient engagement is also important. So I flagged the workforce education, not only because knowing that Joplin is and Missouri Southern is part of the Joplin Regional Alliance for Healthcare, is really enthusiastic about this, but it's also just in general a really important part of all of this because AI is developing, precision healthcare is developing. We need to also have, again, that continuing professional development to be aware of how do we use this, what should we be mindful of with regard to the strengths and limitations of AI. And then the data shortfall. So we have to have diverse data, again, representative of the communities in which we are treating our patients. And then we have those large databases, the ones that were developed by the government that were hundreds of, thousands of individuals. That's very helpful, but it's really important to make sure that the data is relevant to this community as well. But then being able to merge those is helpful. And then a question had come up yesterday at a meeting with JRA, which was about the workforce and the types of jobs that will be needed, and essentially the medical and healthcare data analysts. So any of you who are interested in that, there's potential there. The healthcare AI engineer, the ethics, governance, and compliance specialists, and the healthcare cybersecurity and data privacy specialists will all be areas of importance. Serving the underserved is essential. We know that patients need not only access to care, but in a timely manner, and they need to be able to be having a trusted relationship with those who are providing their care. So mobile care units and telehealth and point-of-care testing, we know that's going on in the community, which is great, and we need to continue to advance that along. We know that with regard to overcoming barriers, there are a couple of things that might be of interest in Jefferson City. So, for example, there is legislation that is pending in Jefferson City, great legislation on prior authorization reform that passed the House. We're hopeful it will pass the Senate as well, but it has some really important provisions in that. Legislation that is hopefully forthcoming, it is a priority for the American Cancer Society, Cancer Action Network, is to have biomarker coverage. That is to allow the patients to be able to have really the best medically evident care that is going along with clinical treatment guidelines using biomarkers, and to have coverage for that is important because we need to have the insurers pay for that, and again, cost effective. You get targeted treatment, less toxicity, benefit to the patient. That should more than hopefully offset the cost of any expense there. So the resources, just a couple policy items. The bottom one is the most recent with regard to our principles and policy on augmented intelligence. You might want to take a look at that if you're interested in policy. Here's some others on the patient perspectives with regard to data privacy and guidelines on digital health, and the importance of having, if we have any AI-related tools or digital health tools, privacy is paramount, and it needs to be respected at the beginning. Privacy is good business. The ones that are in yellow are ones that you might particularly like to take a look at. This is a monograph. It's really excellent. I didn't write it, so I'm just really a big fan. I've read it more than once. And it tells you case studies, uses, thoughts to consider if you're going to be embarking on using AI, how you can use it on the administrative side or clinical side of taking care of patients. It's really excellent. And then there's the ChatGPT and generative AI cautions document. Again, I encourage you to take a look at that if you're using large language models such as these in clinical practice. And then these are all great resources on the Ed Hub with regard to artificial intelligence in healthcare, with regard to AI and precision health, and the future of AI and precision health, and what stands in the way, and augmented intelligence in medicine. So I encourage you to take a look at those resources and read more. These are some collaborative educational pieces that are also might be helpful. And the takeaways are precision healthcare is an approach that considers individual differences in genes, biomarkers, psychosocial, and phenotypic factors to tailor disease prevention, diagnosis, treatment, and prognosis. Precision healthcare has the potential to improve effectiveness of patient care, enhance patient safety, and optimize patient outcomes. Again, AI drives precision healthcare, and AI augments the human ability to analyze and interpret with regard to data, complex data, and performance this efficiently to help clinicians develop and deliver a tailored approach to individual patients, and through effective policy and advocacy, education and collaboration, we can work together to overcome barriers and help to achieve the realization of the potential of precision healthcare. This is my contact information, both email and social, and I look forward to your questions. Thank you.
Does anyone have any questions? We have a couple of portable mics. We'd be happy to come to you.
Hello, I'm Tracy Solia. I'm the Director of Clinical Applications here in Joplin at Access Family Care. We serve the underserved population. We are currently using AI for ambient listening. However, we do not have any decision support yet. My question is, how is the AMA working with healthcare vendors, IT vendors, to help support decision support with AI? Because we have a lot of providers who are concerned about decision support. Is the AMA working with the, like Epic, and we using ClinicalWorks, some of the other healthcare software that's out there?
Yeah, so AMA has been involved in advocacy and at the federal regulatory level as well for what was used to be called ONC, the Office of the National Coordinator, that then can influence the vendors. The AMA has conversations with vendors as well, but having the entity to which they are held responsible then have them be those who are involved, in those decisions, and to make sure that any clinical decision support tools adhere to the guidelines, the state of the art, that makes sure that it is sound. And again, it's so important, like we said, that the AI be ethical, equitable, responsible, and transparent. And so, obviously there's only so much influence that can go forward, but it's definitely, as you've said, a crucial area that needs to be addressed.
Okay, thank you.
Anyone else? Questions?
If you think of anything later, you're always welcome to come up to me later. I'll be here for the duration, so thank you again very much.
Thank you.
Thank you, Dr. Heine. It's really great to have you help us kind of understand how precision health is really going to work with our physicians to more accurately diagnose and predict which treatment is going to work best for us with the best outcome. So the future looks great.